Welcome, everyone, to the Four Eyes podcast brought to you by YoungOD Connect. We give you a clear view into the young optometry world across Canada and the US. And we are your hosts. I'm Dr. Amrit Bilku.
And I'm Dr. Deepon Carr. Hi.
And we did not have an episode out the month prior. So I was just telling Deepon, I feel like just because we didn't talk for 1 month, it feels like I haven't talked to her in like a year.
Yeah. It feels weird.
Like, yeah. You know, it's like that true friendship where like we don't have to text each other every day. We just log on when we know we have to record.
But I do feel like I've seen you recently, even though, no, I did see you physically.
No, you did recent. No, I was in
What was
Calgary
that?
so long ago now.
Oh, that feels recent.
Like in, I think I was there in May.
No, because I guess I see you every month. That's why I'm like, oh, I've seen her recently.
Yeah, exactly. It feels like we hang out all the time, so it doesn't matter. But skipping 1 month felt like a really, really long time.
That's true.
So update me in your life in the last month. What's changed?
What has changed in the last month? Well, now it's getting colder in Calgary, Alberta, but not as cold as you guys. Don't you guys have a winter storm right now, all the way in the East Coast?
Yesterday was Sunday. That was the first snowfall of this winter. I love snow, so I was so happy. And it was a Sunday, so didn't have to really leave the house, didn't have to go anywhere. Career-wise, I've had a big shift. So I stopped working at the associate position that I was at part-time. Yeah. And now I've transitioned into working full-time at my private practice at Northern Site. And it was kind of a weird decision. It wasn't really something that I was ready to do, but just with the circumstances, I was kind of pushed into doing it, like taking a leap. Right now, I'm in this weird stage where like I'm not profitable. I'm not paying myself from that office. But now it's like I have to dedicate more time to that office to make it grow so that I can pay myself.
Yeah.
So I feel like this in this weird state, like I should be proud that I'm like an owner of a practice, but I'm unemployed. like I just looked at my husband one day. I know I looked at my husband one day and I was like, I have zero income now. Like I feel homeless. And he's like, shut up. You're being dramatic.
Yeah, so I would say like a little dramatic, but that's the life of I feel like an entrepreneur. You just build something and then it just takes time. But then you reap the rewards later.
Yeah.
So it'll be good. Your hard work will pay off.
Oh, so. I'm hoping. So now are you officially down to like working only 4 days a week or 3 days a week?
No, 4 days.
4 days a week. Oh, that sounds so nice.
I had to do it mental health wise. It was just too much doing 5 days with patient care that much for 5 days. I mean, we talk about this in our episode on mental health with Dr. Meenal, right? So we kind of go into detail about all of that stuff. And I don't know, I feel like most optometrists kind of follow this trend. They'll do the 5 days for a bit. And then I notice the older optometrists start, after 10 years, you're kind of like, I'm going to go down to 4 or 3 days.
Yeah.
If you have that, privilege to do that. But yeah, I mean, I've just been doing 4 days for about just a year now. And it has really helped my mental health. Like I'm a lot more happier and easier to be around, especially my staff. I'm not like
freaking
internally
out, like typical
angry
Deepon.
And just like, what is going on? Like, so I'm more like, it's okay, guys. I understand. I don't care. I have a day off tomorrow. It's fine.
For anyone listening that's like a young OD, man, it's so true. The older you get and the more seasoned you get in your career, I feel like it's not like the more grumpy you get, but like the more picky you get. Like even for me, like I said, for the last couple of months before leaving that associate position, I finally had 2 days off in a row. Like I finally started working only 5 days a week and I had Sunday, Monday off. And now that I had to transition into my office full time, I have Sundays and Tuesdays off. And even though it's still 2 days off a week, it's not 2 days off in a row.
I know.
And I am now more grumpy than I was 2 months ago when like I'm so grumpy. I'm like, oh, it's Sunday night. I have to go to work tomorrow. And my husband's like, you have Tuesday off. I'm like, it's not the same.
It's not
Like
the same.
it's
It
you
isn't.
just get so grumpy. A patient care takes so much out of you that you really
Yeah.
need those days like together to just disconnect.
But it's true. As you get older, as you become more seasoned, you definitely become more pickier about
Hmm.
how you're practicing, where you're working, as you
Yeah.
should, because you don't want to be run over all the time. You have
Yeah.
boundaries,
Very
stick
true.
to them. Yes.
Moving on to the topic of the episode today. This was actually Deepon's idea, and I can't believe I didn't think about it because I talk about BV stuff all the time. We figured that, again, a lot of listeners are students, which is amazing. I love hearing every time when students say that they listen to the podcast, and
Hmm.
new grad, young ODs, fresh out the womb of optometry graduation. And
Yeah.
obviously, again, BV skills, BV testing. There's still so many docs out there that are just not comfortable with it or just don't know which test to focus on. So we wanted to make today's episode just like a quick crash course on BV testing in primary care. What tests
Hmm.
should you even focus on? What tests should be routine? What tests can you do that are more diagnostic? And then what test results should be like red flags for you to refer out or just, have them come back to do further testing. I kind of am more interested first in knowing Deepon's perspective since you're a primary care OD. You definitely know a lot more now about the BV system, but as a primary care doc, like what are the tests that you actually focus on? Because I know I can just
Um,
dive into it, but yeah, let's get your
yeah.
perspective first.
So when I get especially kids in, I'll definitely ask about like during case history, I'll ask about what grade they're in, how they're doing in school. That's a big one for me now.
Hmm.
Because I'll be like, what's your favorite subject in school? What don't you like in school? Because it gives me an idea of how their eyes are working in their daily life. Then I'll ask about hobbies. Like my case history for kids is much longer, I feel like, than
Yes.
like the
Yeah.
actual exam, which it never used to be. So when I was a fresh new grad, I don't like I didn't really ask too much about case history. I really just asked like, "Oh, do you have headaches?" "No." "Oh, do you have any problems like double vision, any
Yeah.
whatever?"
Headaches, eye
"No."
rubbing,
"Eye
squinting,
rubbing."
done.
Yeah. And I would
Hmm.
mainly get the parents to answer for the kids. Like I would
Yes.
straight look to the parents
Yeah.
and be like, "Yeah, can you answer some of these questions?" I would just ignore the child and I'd be like, "Okay, what's going on?" But
Yeah.
now I kind of directly talk to the kid, even if they're 6 years old, and I'm like,
Hmm.
"What's going on?" Like, and that's hard for me. I'm not a kid person. Okay. So
Yeah.
but no, I try to talk to the kids, see what they like in school, what they don't like in school, kind of gives you an idea of how they're using their
Yeah.
eyes. And then I'll definitely do cover test,
Hmm.
and then accommodative testing,
Hmm.
like the push up or minus lenses.
Hmm.
And then what else am I thinking of? That's pretty much
Yeah.
all I get to.
And
I
I
don't
I
do
don't
the
think
virgences or anything like
yeah.
that unless it's like they're struggling in some
Hmm.
way, if it has something to do with that. But usually I don't do any of that.
Yeah.
So, yeah, mine is very, very small. So,
I think yours
accommodation,
is a very fair
cover
answer and
test.
pretty normal, right? For
Yeah.
like what a lot of primary care docs will do. And for new grads, like again, we've talked about this many times that most of the job opportunities that you will get, in your first year out of school are probably going to be settings where it's more high quantity, high volume of patients. So your eye exams are shorter, right? You have to be
Mhm.
quicker. You have to stack patients every 15 minutes, dilate one, get the other one ready. Yeah, there's no time for you to really sit down
Yeah.
and analyze their BV system. And that's fine. You don't have to. So don't feel the pressure to. But it's a great thing to just have in mind. What are the, basic tests that you should be doing to screen on everyone?
Hmm.
When should you stop and really start to evaluate? And then, like, when to refer, right? If you're not comfortable dealing with what you see, or when should we be more concerned that it's something else? First of all, case history, that's amazing because I would say that is kind of doing a bit more of a BV evaluation when you're asking kids and teenagers more questions just about school. And
Yeah.
I think a huge tip with that is if you're not comfortable with kids or in general, you just don't, have a good vibe when kids come in the room or you don't know how to really connect with them, you just ask them those questions because, first of all, they are distractors. And
Hmm.
then also, when you're asking the kid those easy questions that they can answer themselves, how old are you? What grade are you in? I even ask, what's your teacher's name? Because they all friggin' know they love their teachers. So they're just questions that they can answer easily. They feel more comfortable that, okay, you're not a
That's
scary
true.
person.
Yeah.
Yeah,
Hmm.
you're not a scary person. You're not mean. You're just asking them questions that they know the answers to. They feel more confident and then they're ready
Hmm.
for the exam.
Hmm.
And yeah, asking favorite subjects is a huge giveaway. If they love, language, science, math, if they love those sorts of subjects, you know that they like to read and write and they like to enjoy
Hmm.
that stuff. And if they say, I like gym, I like recess, I don't know, I don't like anything,
Yeah.
then you know, okay, they're struggling in school for a reason. And if there's no, subject that they love in general, they probably hate everything in school because it's just hard for them to
I
see, read,
sometimes
and focus.
I will ask the parents about grades too. I'm like, is
Yes.
everything in terms of reading level okay?
Hmm.
Or is there something that they're struggling in quite
Yeah.
a bit? And yeah, and then the parents will be like, "Oh yeah, there's a lot of issues with this subject," or "No, they're
Yes.
excelling." So
Yep.
that kind of gives me okay, like
Ask
you
the
like
parents second. Yeah,
yeah.
because it's like get the back. I mean, trust me, sometimes even I have to pull teeth out of kids to even answer one question. What do you
Yeah.
like about school? Okay, let's ask mom. What does Timmy love about school? And then,
Yeah.
parents will kind of pitch in their
Yeah.
opinions. So that's already doing like a BV workup right there. You're already getting hints of are they struggling with anything or not. I totally agree that, your main BV testing out of Phoropter, that's going to be really quick and easy in the beginning, is your cover test and your NPC, right?
Mhm.
Your cover test is checking the posture of the eyes, making sure the eyes are aligned, making sure they're straight. Is there a huge phoria that, can cause a lot of fatigue for the kid? Or is there a strabismus? And is it, intermittent? Is it happening occasionally? Or is it constant happening all the time? So that you would want to do when you start the eye exam, before getting them behind the phoropter and everything. Then you do your NPC because, yeah, in primary care, this is my personal opinion again, and it all depends on your state or your province of, what requirements you need to fulfill a primary care eye exam. But, you don't need to do Virgins ranges
Mhm.
in a primary exam.
Mhm.
Because your Virgins range, you are already testing convergence range by doing an NPC.
Yeah.
So if that child can converge accurately on an NPC and their ocular posture is pretty normal, then you've already made the educated assumption that their divergence range is pretty good too. So you
Yeah.
don't need to do the whole base in, base out ranges.
Yeah, I forgot. So I do
You know?
NPC as well, but I won't do it once. I'll try to do it like I'll
Yeah.
try to tire them out a little bit
Yep.
more
A few
too. So I'll do it
times.
like maybe even 3 to 4 times,
Yeah.
depending, just to see if I'm hopefully not missing anything.
You could do it two
Um,
ways, actually. You could do it a few times, which is what we learn in school. Do it 3 times and repeat it. I've also noticed that you could also just do it very slowly because
oh
you do it
yeah.
very slowly. You also
Yeah.
can kind of see, okay, what's
See.
your stamina? Like for
Yeah.
how long can you hold this
Hold this.
convergence posture for? Is it comfortable? Are you
Yeah.
starting to notice their eyebrows, sort of squint?
Yeah.
Um, it all depends on the kid, how much attention you can hold, because
Yeah.
in my opinion, when you do NPC multiple times, I have seen doctors do NPC 100 times over. You guys do it way too fast. Okay. Way
Mm,
too fast. So, what's the point of doing it really fast 3 times
yeah.
when they might not even be processing, like, what are my
What's
eyes even
going on?
doing? If you go slow enough, you'll probably even tire
Catch
them
up.
out the first time
I know that's
to
that's why I
get
do it like 3 or 4 times. Like I think I missed something. I
because you
think I
do it
missed
fast.
something.
Yeah,
It's just like
exactly. Right.
and they're like, "Oh my God.
Yeah.
What is she doing?" Yeah.
So, your cover test and your NPC is already going to tell you if they have any sort of avergence issue, if their eyes are not able to coordinate and be aligned. And then you're going to do your stereopsis testing.
Yes,
So,
which is what we do in
yeah.
pre-testing. So
Oh,
stereopsis is
yes.
always something we do in pre-testing.
Great. Yeah.
So that's another thing that's always looked at. Yes.
And your stereopsis in primary care is going to tell you two things, again, in my opinion, of how I understand stereopsis now. So when you do those RANDOT forms or the random dot forms,
Hmm.
that is telling you is there a signal going to both eyes at the same time? So are the both eyes aligned at any point, or is one eye always misaligned? So if you get no random dot stereopsis, there is a permanent constant strabismus
Strep. Yeah.
there. Something is there. If you don't see it, then it's micro, but it's definitely a strab. And if they are able to see those 3D images, then even if you see a strab, it is not constant. So
Yeah.
it is high frequency happening a lot of the time, maybe if you always see it turning. But if they have some stereo, there is a signal going from the brain to both eyes at the same time. And then when you go to the local stereo, so usually those circles
Mm-hmm.
of seeing which circles pop out more. Now you're measuring, okay, what is the quality of those two signals going from the brain to the eyes? Is the signal strength in both eyes equal, or is one signal maybe stronger than the other?
The other.
So that's why
Mm.
then you'll see kids, who get poor stereopsis, less than 40 seconds of arc. That means, okay, well, both eyes are working, but one eye is probably more dominant at some
Than the other.
point when they're doing that test. So now you can then consider, do we need a prescription adjustment? Do we need an ad
Mm.
power? Is there a high phoria posture that's causing, one eye to be more dominant than the other? Is there a difference in their accommodation in each eye? So it's something unusual in their BV status that's causing some reduced stereo. And after those three, I feel that a lot of the other BV tests you can do, most people in primary care are going to do behind the phoropter.
Mm-hmm.
So after you measure your prescription, you do your RET, you do your subjective refraction. I feel like the most common things people do afterwards are NRA, PRA, and
Mm-hmm.
then monocular minus lens amps in the phoropter. Because I
Yeah.
guess you
I'll
already,
do the monocular minus lens amps on older kids that kind of basically understand the instructions
yeah,
because that's pretty subjective too. So you gotta be
yes,
careful of how
yes.
you're analyzing those results. Yeah.
And I'll tell you honestly, everyone who does, like everyone listening who does inferopter BV testing, I personally believe that's why you don't like BV testing, okay? Because honestly, like these
Yeah.
kids, yeah, you cannot properly explain these instructions to kids because we were taught the instructions for adults and now we're robots, so like we
Hmm.
can't adjust the words that we say. And then yeah, you cannot understand or trust what they're seeing behind the phoropter. And then
Hmm.
it annoys you because then you're like, I don't know what the hell this kid is saying. Like it doesn't make
Yeah.
sense. And then they're taking forever. And then you're like standing there like, oh my God, just pick something.
Yeah.
So in my honest opinion, that's why I don't do any inferopter testing anymore.
Yeah.
Everything is actually much, much faster when you do it out of Phoropter. Like, for example, if you take one popsicle stick with a sticker on it, you have them do cover test with that popsicle stick, NPC with that popsicle stick, and then you cover one eye, and you can do your push up amps or your pull away amps with that popsicle stick, and you have done now three tests in 1 minute with a
Hmm.
popsicle stick from the dollar store.
Hmm.
And you can put, and the popsicle stick has four ends, right? So
Hmm.
you can
Okay.
put four stickers on the popsicle sticks and change them to keep them engaged, right? Oh,
Engaged.
what's
Yeah.
this sticker now? I changed it. Oh my God, I flipped it. What's this one? I mean, it's so much faster than doing minus lens amps in the Phoropter.
That's true. Yeah.
Yeah, and the only test that I agree would be nice to do in the Phoropter, which is easier, is NRA PRA because
Hmm.
you're already in the Phoropter. The near card is right there. You can do your NRA PRA, which basically measures the flexibility of their accommodative
Accommodative
and
system.
vergent system
Yeah.
together. So how does their accommodation and their convergence or their divergence work at the same time? But again, if you want to try just doing everything out of Phoropter other than your subjective refraction, you can just grab those plus minus two flippers,
Hmm.
grab the near reading card that they already, had looked at before,
Hmm.
show them like the 2040 line of letters, or if you have the cards that have like the words on them, just put those flippers over both eyes, flip once, flip twice, one more time each. Can you make these letters clear? What do you see? What letters can you read?
Yeah.
That is your NRA PRA out
Ooh,
of
that's
phoropter.
faster. Yeah.
Yeah,
No,
it could be faster if you just, you reach over after that popsicle stick is done. You've done cover test, NPC, monocular amps. You put that popsicle stick down on your desk. You grab the reading card and your flippers, and
yeah.
you have them hold the reading card, put the flippers over both eyes, one side, read those letters for me, and then halfway while they're reading them, flip the lenses and
And
see
it's
if they
better to
still
do it
go.
at plus and minus two.
±2, yes, for pretty much most kids under, like under teenage years.
Mhm.
Once you're a teenager around, 14, 15 years old, you can go to a plus minus 150.
Yeah.
But still, that plus and minus flip is measuring their accommodative vergence facility. How
Yes.
flexible is it? So you're doing the same test. And if they pass with flying colors, they can see clearly, they can read clearly, you are done all your BV testing right
That's
there.
true. I mean, you're
That's it.
right. All the infropter testing I do, I'm like, I hate these
Like you
people.
don't look forward to it. I hated. I
No,
did NRA
because I'm
PRA
like,
for so long and FCC. I loved doing FCC like 2 years ago. I did FCC on everybody. Now I do MEM retinoscopy. So it's the
yeah,
same sort of concept. But man, yeah, in the phoropter, it's just so much talking in the phoropter,
yeah. And
explaining the tests and
I feel like kids don't, if they're not looking at you, they're not paying attention. So when you
Mhm.
have them in the phoropter, they're like, what is she doing? What's happening? What's going on? And then you explain the instructions and they're like, huh?
Yeah.
You're like, I hate you. Please just get me through
Yeah.
it,
And of course,
please.
I mean, I think, yeah, teenagers are easier to just,
Hmm.
sit them behind the phoropter. But that's it. That hits all of your major BV tests to just screen them and see is anything wrong.
Okay.
I personally do not measure ACA ratio. I have a lot of
Oh my
ODs.
God.
I
I don't even remember
know.
what that is.
I have a lot of ODs
No.
DM me on Instagram and ask for like help with cases and stuff. So they'll be like, I got this ACA ratio. Like, how do you measure it? And what do you? And I'm like, girl, I don't freaking care about ACA anymore. Like, if you are measuring an ACA ratio, you are now doing more like investigative BV stuff. Like, you do
Yeah.
not need to waste your time doing that in a primary care eye exam. Again, because I think my philosophy has just changed now. The concept of ACA is to understand how many diopters of a prescription do I push in someone that will change their phoric posture, right? Like that's what it
Sure.
is.
I
That's
must have
yeah,
blocked this out. I'm like, I remember
suppressed
ACA. I'm just like,
suppressed all these
no,
things.
just gonna.
I mean, all of our listeners probably know ACA more than us
Yeah,
because you guys are all like freshly graduated. But yeah, ACA
I
basically
know.
means how many diopters of, plus or minus can I put in front of this eye to change the ocular posture by how many degrees?
Mm-hmm.
So, yeah.
Hmm.
So, how
Sounds
many,
familiar. Yeah.
something like some nonsense like that. And again, it's just going over it's based on the theory or the concept that when you push more minus, you can improve an exo. And when you push more plus,
Right.
you can improve an ESO. And
Mm-hmm.
again, if anyone follows my content and knows how I prescribe or has seen and heard my cases, I don't believe that is the way to prescribe to straighten out eyes anymore.
Mm-hmm.
That's you trying to mechanically manipulate their eye posture by just pushing higher prescriptions.
Yeah.
So either way, but I don't judge anyone who does the ACA. I mean, it's still valuable information, but not something you need to do in primary care. Vergence ranges, the prism range, Risley prism, get out of here. Get it out. No, no.
I know.
You
If
don't
anyone
need it.
comes to me and they're like, "Oh, did you check the ACA ratio?" I'm gonna be like,
Who?
"What?" Refer. Like,
Yeah, right?
who?
So
Yeah.
in terms of testing, honestly, when we summarize it that way, I hope it sounds a little bit more quick and easy to just do all those components in a quick 5 minute like part of your primary care eye exam.
Yeah.
If it's out of phoropter, I promise you it will be so much faster.
And like this, your advice is basically for people. like me who are not BV people.
Mhm.
Like I,
And not
I'm not,
peds people.
yeah,
Yeah,
I'm
you're
not a
not a
peds
peds person. You're
person.
not. Yeah.
I'm not a BV person. So I'm just trying to figure out, okay, what's going on with this kid or whoever, and
Yeah.
if they need to be referred, then that's what I'm going to be doing next. But of course, if you are more interested in BV and
Hmm.
you're in primary care, yeah, investigate further, do that ACA ratio, do
Yeah.
those Risley prisms,
Yes.
do it, see what you get. But this is for like people are like, okay, BV's not my thing, like me. And it's like, okay, what do I need to do to make sure everything's okay? And if it's not, what do I got to do next to get
Yes.
this kid successful in life, basically? Yeah.
Yeah, exactly. And so, yeah, what do you, I guess, actually, Deepon, I want to know, what do you do if something is abnormal? Like, if
Refer.
there, honestly, it should be that easy, right? Refer. Even
No,
refer within
dude.
your own clinic. Like,
Yes.
we
Well,
all work
yeah.
in clinics with multiple associate docs. Like,
Mhm.
there are other docs there. Your kids can always come back to the clinic for a follow-up for a second opinion with another associate doc. Like,
Mhm.
if you know that someone in your clinic does like peds or they like BV, you can ask them questions, bring the kid
Well,
in.
so I now work with another OD who loves peds, loves BV, and I will
Thank
refer
God for you.
everything to her. And she knows that. So
Yeah.
I mean, like any kind of um exotropia, eye turn, if I'm just feeling very like, okay, uncomfortable, and I think my prescription is not changing anything,
Hmm.
I'll refer the patient to this other doctor.
Yeah. Yeah.
And I trust her. Like she sends me reports back and stuff. So
Hmm.
we have a pretty good relationship, which is nice. And then anything accommodative though, you know what, I'll try to work on those on my own. Like I'll try to do plus lenses, see
Yeah.
how they're working that. I'll do follow-ups with that. But even then, if the follow-ups, like if there's some possibly amblyopia that's taking place and I'm like, okay,
Hmm.
this isn't getting better,
Yeah.
whatever I'm doing is not changing the status of this
Hmm.
patient, then I'm referring to this
Yeah.
other doctor. So yeah, I mean, and if you don't have that with anyone yet, I would suggest, I'm sure there's an OD that loves peds, that loves BB that's near you. Just have to find them and
And
look
not
for
even,
them.
yeah, and you don't always have to refer. I know that that's where Deepon and I are really big supporters of, internal referrals to like other ODs. Like, we should be supporting our colleagues. We should be,
Oh yeah,
referring all the time.
I
But if
honestly
you,
don't refer to ophthalmology for any eye turns half the time. Like or
yeah,
most of the time.
yeah,
Even
like
if the
support our
patient
own
asks for it.
profession. Yeah.
Yeah, I'll get them to see this peds optometrist first, and I'm like, if she thinks it's necessary, she'll
Hmm.
do that. But I will always be like, let's see what she says
Yeah.
first, and then the decision can be made from
So
there. But
yeah, that's one of my big tips for you guys listening, that you don't always have to feel the pressure to refer, because I know a lot of people don't want to do that. Also, if you're an associate, you're working for an employer or like someone who's hired you, and that practice owner might also feel a little, why are you sending this patient out
mm,
when like you can handle it here? Like, we don't want to lose business. We don't
yeah,
want to lose a patient, right? 'Cause that all that political stuff does get in the way sometimes of
yeah,
how we make clinical decisions, unfortunately, but it's
hmm,
true. And so even if you don't want to actually refer and you see some BV finding that you're like, I tried my own prescription, I tried adding plus or adding prism, and
hmm,
I don't know, it's not really getting better, call a BV doc, text a BV doc, DM them on Instagram. Like, you must know somebody that likes BV and that loves it. Just message them and schedule your patient back for a follow up to be like,
hmm,
I'm going to consult with another doctor. I've done that for glaucoma
hmm.
because I know I should have the confidence enough to manage glaucoma without crying. And and so when I see a patient with glaucoma where I'm like, okay, their glaucoma this is not severe. This is not terrible, but I really don't know, like, should I prescribe drops? Should I send them for SLT? Like, what should I do? Sometimes I'll have them come back for a follow-up and I'll be like, I know a really good glaucoma optometrist. I'm going to give them a call this week and I'm going to get their opinion on your findings. And then I'm going to bring you back once I talk to
Yeah.
them and then remeasure you. And then let's go from there. And patients love that because then
Yeah.
they think, wow, this doctor is going to go home after work and still think about me or think about my kid and consult another special doctor to like get a second opinion.
Hmm.
And the patient doesn't have to do anything, like they don't have to
Yeah.
go to another clinic. They don't have to pay
Yeah.
for another exam.
Exactly.
And
Yeah.
that's a great way to build stronger connections with those kids or whatever BV patient you have. Just call that BV doc and be like, hey, I have a case I need help with.
Hmm.
And, what do you recommend? What should I test? What should I try? And then you try the recommendations when you have them come back for a follow up. And I've done that so many times for people. Please
Yeah.
don't take that as a hint to message me. I don't respond back for like 3 to 4 weeks at a time. But but in general, yeah, do that. If you don't want to refer or you're kind of like, I don't want to make it look like I don't know what I'm doing with this patient, just be like, I'm seeing something. I'm gonna get a second opinion. So let's have you back so we can do some remeasurements and
Yeah.
figure it out then. Done.
Yeah. I think that's a really good way to go, especially, yeah, with BV stuff. Again, sometimes findings can be really confusing
Yes.
and sometimes results conflict with each other.
Mm-hmm.
And you're like, I have no idea what's
Yeah.
going on. And sometimes you just need a moment to think about what the results actually are, which
Mm-hmm.
is fine because again, we're in primary care. These are like 20 to 30-minute exams. The next person's already coming in. You don't
Mm-hmm.
have a lot of time to comprehend like what the results are all the time. But I
Yeah.
think, yeah, just taking that extra step to be like, hey, you know what? Let's do a follow up in a couple weeks or a month or something. Let me figure this part out and
Yeah.
then we'll go from there. I think
Yeah.
patients are always happy that you're monitoring them or following up with them instead of saying, okay, see you next year. Hopefully things work out. And you're just
Yeah.
kind of like, well, I just left them to be on their own. Right.
Yeah.
So, yeah.
And I kept debating if we should spend time on this episode going through what to further investigate when you see a BV finding that's abnormal. But just like you said, Deepon, like I don't think that's an easy episode to go through
No,
because there
yeah.
are 100 different BV issues, like what eye muscle is moving out, which eye is doing this, and what eye is not focusing. There are so many BV issues out there. I don't want to go through all of them, but
Mhm.
what I would recommend are some easy ones that you can
Mhm.
try to fix yourself, or just try to, help out in
Yeah.
primary care. And I really want to stress the point of just when you see something abnormal, you can definitely apply your knowledge of whatever you learned in optometry school or with any other courses you've taken. Try to prescribe something to alleviate that BV issue. But then my biggest tip after, which I don't know how many doctors really do this, repeat all your BV testing with the new prescription. I find that a lot of
Mm.
doctors, especially when it comes to amblyopia, especially refractive amblyopia. Refractive amblyopes, that is a BV issue, and they often do have reduced stereopsis.
Hmm.
They have poor tracking. We didn't even talk about tracking. When you basically do your EOMs,
Oh
I
yeah.
mean, you're basically checking pursuit. So you've
Yeah.
already kind of done your tracking. You don't need to do the whole monocular saccades. You
Yeah.
don't need to do that in primary care. But you'll notice that their pursuits, like their tracking on EOMs, could be off.
Hmm.
Their fixation is a little, all over the place. Then their accommodation is worse in that amblyopic eye. So when you start to prescribe something, trial frame that prescription and then repeat all of those tests. So again,
Hmm.
you might want to do that at a follow up before you prescribe. Check the stereo again and the EOMs and the cover test and the NPC and the amps. Like
Yeah.
check all of it because you might notice maybe an improvement in like one BV finding, but then maybe you've changed some other status in the eyes, right?
Hmm.
So especially when we prescribe, plus lenses,
Hmm.
for things that, you can prescribe plus lenses for things like accommodative insufficiency, even a poor NPC, you
Hmm.
can definitely try to prescribe some low plus lenses, maybe like plus 0.5 or a plus 1.0. But then again, repeat those tests and
Yeah.
see how much improvement have you given. And if you're going to give extra plus for near, check everything else too, just in case. Is there any, did you change their cover test posture? Are
Mhm.
they more ESO now? Did they become EXO now? Like too much EXO?
Yeah.
Then you can finagle your prescription a little bit more. You can like kind of like reduce it, increase it. You can kind of like tweak it around.
Yeah.
Because I find that a lot of docs don't repeat their testing and then
No, I
just
don't
go on a
actually.
whim.
So that's something
Oh,
I
yeah.
probably should do. I'm like, oh, great. You can see better. Any problems? No?
Yeah.
Good. We're on the right path. So,
Even
but
for
no,
like
that's true. You
accommodative
can definitely
insufficiency,
repeat it.
that's such a common one, right? Like
Yeah.
we know that with AI, adding plus can help. But then how much plus? Are you just
Mm.
giving plus to improve their AMP measurements? Because
Hmm.
now what have you done to their NPC? What
Yeah.
have you done to their cover test? If you've improved all of that, then you can be like, hell yeah, we're going to give you this prescription and you can
Yeah.
feel so confident. But now, if you've improved their amps and then all of a sudden they become this like large EXO because you've given like plus 150 of an
Hmm.
ad, then you're like, okay, shit, I need to
Yeah.
like tone it back now because I can't have one finding good and then the other not.
Yeah.
Um, so I would just recommend, I'm not going to go into details of how to prescribe. I have a whole 10-hour course on that. And there are other BV docs who have courses on that.
Yeah.
But whatever you prescribe, remeasure all of your BV tests.
And yeah, you could do this, like you said, at the follow up. This is not all obviously in one test because they would, you can trial frame them at the follow up,
Yeah.
see how it goes. But no, that is something I do not do and I should do. Repeat the
Hmm.
BV testing when they update their prescription to what
Yeah.
they give them.
Yeah.
That's a really good point.
When to refer for like a neurological issue for a BV finding.
Mm.
I find that that's a tough one, especially for kids that have ESOs,
Hmm.
kids that are developing a strab, adults that have developed a strab, nystagmus situations. If you see a kid with a nystagmus or an
Oh
adult, you're like, oh
God.
my God, what the hell am I doing? Yeah. Tips for nystagmus. I still remember this because I did a lecture on it during residency, but I'd say like the big red flags of any nystagmus in a patient would be, first of all, if it's a vertical nystagmus, because it's just not normal.
Hmm.
So if you see a vertical and the patient's like not complaining of anything, just really ask those questions like, do you know you have this? Like, has somebody already, have you already been evaluated? Because a vertical or oblique, like torsional
Oh God.
nystagmus is
Yeah.
weird. And then also, of course, if the patient notices their world shaking, because
Mm.
a congenital nystagmus, from infancy, your brain adapts to that. So your world does not shake side to side.
Hmm.
But a new onset nystagmus, that's not normal for your brain. And so when your eye is shaking, your fixation is going side to side.
Sides,
So it
yeah.
literally looks like the world is moving. So that would be very abnormal. And you would want to send for a neurological workup, just in case. I feel like and then obviously if they have neurological symptoms with it, right? Any change in their speech, any change in headache patterns, any seizures, any numbness, tingling, anything like that. But I find that for nystagmus, those are like the top three, I guess you'd want to really think about. There are
Hmm.
other red flags for like a neurological workup, but those would be my top three recommendations in a primary care setting. Um,
Yeah.
it's so funny. I had a nystagmus patient today and last week, and I haven't seen
Oh.
one for like years. And I'm like, oh my God, are you normal? Are you normal?
No, I think the last time I saw a nystagmus case in a kid was in when I did my mission trip in Mexico. And it was a
That was a long time ago.
torsional. Yeah, because it scared me because it was
Yeah.
a torsional oblique one. And I was
Yeah.
like, um, I'm like,
Yeah.
you gotta see some
Yep.
like
Get it
neurology.
ruled
And I
out.
think the parents, like when we were translating, the parents were like, "Oh, he's had this for so long," and I'm like, "Has it ever been checked?" No, and I'm like, "Yeah, we
Yeah.
gotta." And he didn't need glasses; like he could still see okay, but he was just like when you looked at him, his eye would just go
Yeah.
like
Turn.
vertical or side to turn right. And
Mm-hmm.
I was like, and I remember all of us were like, "Oh my God, what's going on?" So.
Yeah.
I never knew what ended up happening with him. We did send a referral, but That's I was like, oh my God, if I ever see this in clinic, no. Like,
Yeah.
I was
Yeah. And
like,
and
no.
again, I mean, if the patient's already said they've had a neurological workup or oh, I've had this for years, like,
Yeah.
I've seen doctors, no one's, said anything, fine. I mean, you can still cover your bases, be like, I'm still gonna make that neurological workup.
Yeah.
But at least if they're aware of it, then I would say not as big of a deal. But those would be my top three red flags for nystagmus. Red flag for strabismus, of course, would be new onset diplopia with it, because then of
Mhm.
course okay, this is acute, this is not long standing. And especially if it's affecting like their balance and their coordination, you want to look for any neurological or muscle restriction. So when you see someone with a strabismus, new onset, what you want to do is you want to do your versions, which is basically your EOMs, but you're not doing it in just the H pattern. You're doing it in all 9 gazes. You're
Mhm.
just seeing, okay, in every extreme gaze, how large is the magnitude of that strab? If the magnitude of that strab is pretty close to being equal in every direction, it's more long-standing, so it's
Mhm.
not as concerning. If the magnitude of the strab is changing in different directions, and so you get more than a 10 diopter change in the magnitude in any direction, it's more acute, or there's
Mhm.
some sort of like actual restriction going on. Like
Yeah.
it's not a
Okay. That makes sense.
developmental strab. It's like, no, something is physically or neurologically bothering this eye muscle for it to
Yeah.
be pulling or restricting in one
One
direction
way.
more than
Yeah.
the other. So that might trigger you to then assess, okay, is this now like an actual neurological issue or a muscle issue? Um, We've all learned about monocular ductions where like, they take the little forceps, they grab the conj and they try to pull the muscle. Obviously, we're not doing that in primary care or in B where I'm not doing that either. None of us are doing it. Nobody's doing it.
Oh God.
Can you
I
imagine
can't
me
believe that's right. I
pulling out my
remember.
little claws like, all right, look that
I
way.
remember learning that and I'm like, am I seriously going to be doing this in clinic?
Yeah, like
Like what?
looks very abusive to the eye. But what I learned in residency as like a quick kind of, you know, uh dummy version of doing ductions is just when you have that strab in any gaze that, the strab is present. So let's say it's in left gaze, whatever. You have them look in that gaze and then you cover the good eye and you see how much of that strab eye fixates and straightens out to look at the target. So, for
Hmm.
example, if your eyes are both looking to the left, and let's say you have a restriction in the left eye is not focusing on your target, but the right eye is. You're going to block the right eye. If that left eye doesn't move at all and it's still not looking at the target, you have some mechanical issue. Like
Hmm.
there is a muscle problem. Even though
Yeah.
your brain wants to look in that direction, there's some physical
Something going
barrier
on.
there that
Yeah.
you can. If that eye starts to slowly move towards the target, but it's not completely there, you have a neurological issue. The brain wants to look at the eye, it's making its way there, it's not fully there because the nerve is damaged and there's no complete
Hmm.
signal going there. If you cover that right eye and that left eye fully expands and like straightens out to, or not straightens, but moves to the target and it is on target, there is zero or very low possibility of any neurological or mechanical issue.
Hmm.
It's most likely still a developmental issue. So, like, not a big concern to get neurological testing done. So, that's
Hmm.
my trick with monocular ductions. If you really want to
Mm.
know, should I tell the neuro, to look for any sort of lesion versus like any physical blockage, anything like that with a nerve or the muscle itself? Hope that
Hmm.
makes sense to people.
That makes a lot of
Yeah,
sense. Yeah.
that's pretty much it. I don't really know if there's any other like
I mean, that's
huge
just
red
scratching
flags.
the surface of
Yeah,
BV, but that's what primary care does. So that's
scratch the
what
surface. That's
we'll,
it.
we'll leave it. We will leave it at that.
Yeah, we'll leave it.
But
That was a good summary, I think, for any primary care doc. And if you want to learn more, Deepon and I are always here. I'm always here to help people with their cases. And
Yeah, not
here's,
me.
yeah,
Dr. Bilku will help you with the BB
Deepon will be
cases.
here to relay your message to me so that I can help. Or yeah, like just like I said, you don't I don't know why we still have so many docs that are just not for referrals. Like, I don't know. I don't know why there's so many people out there that really don't want to
I don't
refer.
I
I
don't
don't
think
know
it's always
whether it's
easy
just for
to
politics
like,
or business, or also
yeah,
just like
I
you
think it's
want to
right.
feel
Like
like I want to do it myself. Like I can figure this out.
I think
Fine.
the referral to other ODs has to be welcome too. Sometimes you have to jump through a lot of hoops just to get the patient there, and you're like,
Yeah.
"Oh, okay,
Yeah.
what? What? Oh, right. Well, this is too hard, so I'm just going to refer to ophthalmology because I know they're going to take this patient easily." But
Yes.
sometimes, yeah, I think referrals to other ODs, it's not always a straight path. I wish it was more for
Mm-hmm.
all of us because then I feel like then it would be easier, but
Actually,
yeah,
what
I think it's
Deepon's
just
talking
fine.
about, just to extend, so we have listeners in Canada and the US. So in Canada, we have universal health care. So I think that's what Deepon is kind of alluding to, like
Mhm.
the struggle to refer to other ODs versus ophthalmologists is that universal healthcare in, I assume, mostly all provinces and territories will cover the
Yeah.
cost of the patient's healthcare to see an ophthalmologist.
Yes.
But optometrists, most healthcare is not covered by government funding. So patients have to
Hmm.
pay out of pocket or use private insurance plans to pay. And so if we see something and they've paid for their eye exam and now we're like, oh, you have a BV issue, I need you to go see another optometrist,
Hmm.
it is another out of pocket expense. And yeah,
Hmm.
that is definitely one of the big barriers to us referring to each other, because then the patient is like, I've already paid you. I'm
Yeah.
already annoyed that my universal health care did not cover this for free.
Yeah.
And now you want me to pay to go see someone else. Well, I know that if I see an ophthalmologist, it's free for me. That's what the
Yeah.
patient thinks. And so just send me there.
Yeah.
So yeah, that is a huge fight. I'm sure in the US it's different, but I'm sure like
I think you guys in the US have to pay for everything
yeah,
in
like the
terms of
way your
like,
insurance plans
yeah.
like cover like how many eye exams you can have in a year versus
Yeah.
follow-ups in a year. I'm sure there's barriers too. Yeah,
Hmm.
it's just it is hard to get comfortable referring and to just remember that your patient's finances are not your problem. Like your
Yes.
problem
Yeah.
is, I don't know what the hell's wrong with your eyes, and I need you to go see another doc to
Yeah.
figure it out
Yeah.
so that you don't die. So,
Yeah. Or go blind
yeah, no one's gonna die,
and
but
then
still,
die.
no one's gonna die. No one's gonna go blind. But yeah, like
Yeah.
you just need to build that confidence or that good relationship with some OD to be like,
Yeah.
I'm just gonna refer you. You go figure out the cost with that OD. You go figure out the schedule if you can go or not. But I'm gonna make the referral regardless.
Hmm.
And let's have someone else, help us figure this out. If you enjoyed this episode, please let us know through Instagram, or email us, or you can always, watch our videos on YouTube. We have them there. But yeah, just let us know if there are any other ideas or topics that you want. We actually did this topic based on some listeners who shared that they wanted some BB tips on our Instagram account. So that's it for today. So thank you again for listening.
Thanks for listening to Four Eyes, the podcast series brought to you by YoungOD Connect. Be sure to subscribe and follow us on Instagram or YouTube at Four Eyes Optom for more content. And we'll see you guys next time.
Bye.
Bye.